Okay, Jay. Well, good morning, everyone. I'm happy to do this talk this morning. I've been asked to comment with my local neurology colleagues here in Buffalo regarding the occurrence and the association, the link between NION, which is non-arteritic ischemic optic neuropathy, and semiglutides. And that story popped into the news around the 1st of July this year. So I put together a little PowerPoint for this. And my talk right now is blindness from Ozempic. And there should be a question mark on that. But nevertheless, I do think it is an association. Now, Jay, can you pop in the next slide for me? Or can I do that? There you go. So I'm affiliated with the State University of New York at Buffalo, where I am in the Department of Ophthalmology as an assistant clinical professor. And I am active with a resident teaching and lectures to other departments as well from time to time. The next slide, Jay. So I wanted to divide up my talk into three parts this morning. First of all, what is a semaglutide? What is NION? And what is the association? And I wanted to make it perfectly clear that not all of us are really familiar with semaglutides and what they are. There's probably, except for a neurologist or an ophthalmologist, not a lot of people who are familiar with NION as a medical entity. And of course, the association, which came right out of the news. Next, Jay. So let's talk about semaglutides. And this originated as an anti-diabetic medication used to treat type 2 diabetes, or T2D as it's also known. It's also used as an anti-obesity medication for weight management. It actually is a peptide similar to GLP-1, which is glucagon-like peptide 1. And when I was in medical school, we didn't have this information. So to some degree, if you are an old timer like me, you really don't have a lot of background information on this, unlike the current younger practitioners or people in medical school at this point. It is available either by injection or oral medication. If it is given by an oral medication, the compound SNAC is used to augment the medication for better GI absorption, and that's also used with heparin and also vitamin B12. There are brand names known to most of us at this point with Ozempic, Rybelsus, and Wegovy. And there are literally dozens of new semaglutide medications in the pipeline from different manufacturers claiming to do different issues with diabetic control and weight loss management. So the field is ever expanding. To some degree, is expanding similarly to the field of intravitreal injections for ophthalmology that we're using for control of diabetic retinopathy and also age-related macular degeneration.
Okay, just to pause for a second for ID. This is AA4.
Semaglutides in 2017. The original research and FDA approval said nothing about. He said nothing about vision changes. It is somewhat commonly associated with nausea, vomiting, diarrhea, constipation, and abdominal pain. I've had some patients in my practice who were forced to discontinue this due to those complications and problems. Jay, just so I know, is my audio being broadcast properly on the Zoom?
It should be now. That's been corrected. If we could get Munair N3PQ, are you getting the audio by Zoom? Okay. Now we have a
I'm looking for a
confirmation.
message on my screen.
Yes, we have a confirmation.
Or maybe people can just nod and shake. Barry, I'm watching you. Barry, can you hear me? Got it. Okay, very good. Let me continue. So earlier this year, that's supposed to be 2024, Wegovy was authorized by the FDA to reduce the risk of cardiovascular health, death, MI, CVA, et cetera, et cetera. So there's a new indication, FDA indication out this year, so that would make the drugs even more popular. Next slide, Jay.
Okay, got it.
There are some contraindications to the use of this medication, and there was an issue with medullary thyroid cancer in rodents. And if you listen very carefully to the contraindications broadcast on the numerous television commercials, you hear about this. They do mention men's type 2 and medullary thyroid carcinoma in humans. However, I wish to speak, as far as I know, those contraindications are totally unproven in human beings and were only in a rodent study. The molecule itself is a glucagon-like peptide. It is a receptor agonist. It decreases blood sugar level by mimicking GLP-1 activity in the human body. A side effect in some instances may also increase pancreatic beta cell formation, and the beta cells, of course, are associated with insulin production. It also inhibits glucagon production, and therefore glycogenolysis and glyconeogenesis are decreased when this medication is used. It also lowers appetite, which is the hormonal function due to its agonist. It also slows digestion in the stomach. Next slide, Jay.
Just to pause, this is AA4FL for the Medical Amateur Radio Council Grand Rounds on the Internet with KM2M at the mic. Let's pause one here just for any additional check-ins.
Okay. Jay, can you give me the next slide in my...
Okay, we're going to continue with our presentation.
There you go. So here's a little cartoon that pretty much summarizes GLP-1 in the body. When you eat food, it releases GLP-1 in your small intestine that is secreted. It then goes to your brain to reduce your appetite. It also slows gastric emptying. It also affects the pancreas by suppressing glucagon secretion and stimulates secretion of insulin. Helps to maintain your blood sugar level in the body. Next slide, Jay. The semaglutide amino acid structure is quite interesting, and during the research and development of this drug, some changes in the actual hormone were made. And again, there's a 94% homology to the native GLP-1. There are 3 substitutions that are fairly important. The alanine in number 8 has been substituted with AIB, which is amino isobutyric acid, which helps to prevent enzyme degradation. A lysine 34 was changed to arginine, which helped in the manufacturing process. And that large amount of fatty acid that you see on the molecule is from acrylated lysine, which help to enhance protein binding and also reduce renal clearance. So it maintains the drug longer in the base in the body. SNAC is an interesting molecule. It is attached to the oral medication, and it helps to neutralize the pH of gastric fluid, which enhances the absorption of the molecule in the blood circulation to the acinar cells. Next, Jay. So pharmacokinetics, these medications are highly bound to proteins. The injection is highly bioavailable, unlike the oral. Within a month or so of initiation of the medication, you reach a steady state, and the molecule itself is broken down in the body with protein degradation and fatty acid oxidation. And the elimination half-life for both forms is about a week. Next, Jay. So let's talk about, for those of you who do not know what anterior ischemic optic neuropathy is, it is associated with painless vision loss. There are technically two forms. The arteritic form, which is found in elderly people and also known as giant cell arteritis, or GCA, is a less common form of the optic atrophy we'll be discussing today. It is caused by inflammation and thrombus of the short posterior ciliary arteries, affecting the optic nerve, and it will results in disc infarction, a relatively quick onset of an APD, which is an afferent pupillary defect. Those of us who will recall it, APD by its former name was a Marcus gun pupil, and that arises when you shine a light into the good eye, both pupils constrict, but when you shine a light into the bad eye, both pupils dilate. We as an observer can only see, due to our own visual limitations, can only see the bad eye dilate. That's all we're able to see clinically, but that is an APD, a Marcus gun pupil. Giant cell arteritis, or arteritic ischemic optic neuropathy, goes on to profound vision loss and typically blindness, where the patient may have only limited, if any, light perception in the eye. An angiogram is often used to detect or describe the choroidal circulation. The treatment of this entity is with high dose steroids at first, either oral or IV. Laboratory testing is available, which demonstrates elevation in sed rate, C-reactive protein, and also platelets. IL-6 is also used to study. It's more specific. And when I have a patient admitted to the hospital, I will typically treat a GCA patient with high dose steroids, possibly a gram or IV for several days, carefully watching the sed rate and the C-reactive protein for a decrease in those values. A significant part of my practice, I might add at this point, is neuro-ophthalmology and retinal diseases. I do treat a lot of people with intravitreal injection, diabetes, and age-related macular degeneration patients. Onset of GCA may be associated with temporary vision loss, amaurosis. It's also associated with a myriad of clinical also findings, which would include jaw claudication, headache, pain around the temporal side of the face, et cetera, and if untreated, it can go on to present with bilateral vision loss, and that are typically the saddest patients I have. They have one eye vision loss, and they may present within a week or two of the second, At that point, the diagnosis is made, but treatment is really too late to preserve vision in these individuals. Let's switch over to Nyan. Now we know what we're not talking about today. What we will be talking about is the non-arteritic form of ischemic optic atrophy. It is more common. It can be estimated at 2 or 10,000, 2 to 10 per 100,000 patients over the age of 50 years. The mechanism by which this entity limits vision and causes optic atrophy and damage to the optic nerve is really controversial. It's felt that there are microvascular ischemic compartment changes around the optic disc, either in the prelaminar or laminar areas of the optic nerve. There is no known treatment. However, this entity is in general associated with diabetes and high blood pressure. Approximately 1/4 of patients with Nyan have diabetes, and approximately 1/2 of patients have high blood pressure. It can be associated with nocturnal hypotension. It can be associated with sleep apnea, but the largest single risk factor we have for this is the anatomic presentation of the eye, so-called disc at risk. That is a smaller than normal cup to disc ratio. And sometimes the patients have really no significant cup of the optic disc. It's all nerve. And you will recall there are approximately 1 million nerve fibers in the optic nerve, but the size of the nerve inside the eye varies from person to person. And in some cases, a patient can have cupping, which resembles glaucoma, but essentially what they have a larger than normal nerve. And this type of person would be commonly associated with myopia, for example. The next slide, please, Jay.
Okay, if we can just pause for just 1 second for station ID. This is AA4FL with the Medical Amateur Radio Council. Grand rounds on there, having an excellent presentation by Dr. Dave Rodman. KN2M. We're going to have an interactive discussion with questions and answers by way of HF.
The next slide, Jay, if you can.
1 minute. So this is AA4FL for the grand rounds on the air. Can we have some, do we have any additional check-ins, any late check-ins? Okay, no late check-ins. Let's turn it back over to Dave for his presentation.
There we go. Thank you, Jay. So there are typical signs of Nyan. An APD will be present unless the other eye is also affected. There will be decreased vision, dyschromatopsia, trouble with color vision, color perception, a swollen disc, and splinter hemorrhages. In 65% of the patients, the vision is 2200 or better. However, 1/3 of the people really have significant vision loss, and at least half have 20/70 or worse vision. So if you have a high-tech job or you're driving a car and you lose the vision to that level, you are significantly visually limited. Visual field is interesting, most commonly shown inferior vision loss. The disc edema can be segmental or diffuse. It may even be altitudinal, and the patient may have preserved central vision with an altitudinal visual field loss, yet they have significant visual loss in one altitudinal portion of their visual field. Splinter hemorrhages are found in at least 75% of people, and they are much more common than all other forms of optic neuritis combined. So if you have a patient in your office and you're examining them and they have splinter hemorrhages and a swollen disc, chances are this is Nyan, probably not other forms of optic neuritis or even giant cell arteritis. The vision loss will occur over hours and days, but the patient may also awaken with a vision loss. And in some cases, narrowing of the peripapillary arteries has been observed as common. Jay, next, please. So in general, this is a diagnosis of exclusion. We want to make sure that we're not missing something. Even though clinically we feel this is nigh-on, we would look at the other eye for a small cup-to-disc ratio. That would be highly confirmatory. Laboratory testing. We want to check a CBC. We want to look for platelets and C-reactive protein. If the patient is a younger one, we want to look at their hypercoagulability state. And we'd also want to look at MRI, especially if there's orbital pain or any motility changing. And the swelling of nigh-on may go on for 1 or 2 months. However, it's usually resolves much more quickly than that. So if you have a patient where optic nerve swelling is continuous, imaging is definitely in order. There is no accepted treatment and there is no accepted cause for this disease. Steroids themselves are often administered. Aspirin does not play a part in the resolution or treatment of this disease. Some information seems to state that the disc edema, when treated with steroids, is of a shorter duration than without steroid treatment. However, vision worsening over the first 2 weeks is often found to be stable by about 2 months out. Treatment may improve visual retention at the 2-week level. However, the treatment is somewhat controversial. The patients I've had with nigh-on that are hospitalized, I will treat them similarly to GCA. I'll give them 1 gram of Cytomedrol per day from 3 to 5 days and then taper off to an oral dose thereafter. Younger patients may have better outcomes. And of course, the disease can be bilateral, as I will show you in just a few moments with some of my photographs. Next slide, Jay. So here is a patient in my own practice, my own neuro-ophthalmic practice. The slide on the right is the left eye, which had non-ischemic anterior optic neuropathy prior to the development of the same condition in the right eye. You will notice a couple things about these slides. First of all, on the right side, the optic disc is pinker on the upper part of the optic disc and more pale inferiorly. That would be the segmental part of the optic disc swelling that I noticed before. And on the left picture is the right eye, which occurred later on. You can see the splinter hemorrhages. You can see the absence of the central cupping of the optic disc and the general blurring of the disc margins, indicating that the optic disc is swollen as compared to the right photograph, which is the left eye, where the disc is nice and sharp at this point. Next slide, Jay. This is the same patient later on with angiography, indicating the staining and the swelling of the optic disc. The optic disc is actually leaking fluorescein, but it is very highly confined to the area around the optic disc. And the right photograph shows no leakage because that nerve is no longer swollen. Next, Jay. The photograph on the left is from iWiki. It shows in the black and white diagram inferiorly is an OCT of the optic nerve, showing the high amount of swelling of the optic nerve present, and that nerve is swollen 2 to 3 times more. You also notice the common features of the hemorrhages on the disc, on the edge of the disc, the pallor of the optic disc, and the somewhat dissymmetry of the color of the optic disc, as long as the absent central cupping. So on the next color slides to the right, these are from the University of Iowa. They show the opposite of my patient. In this case, the slide on the right part of the screen shows inferior pink and superior pallor of the optic disc. There's a small cup-to-disc ratio. The disc margins are sharp, and that in contradistinction is compared to the disc on the right, which is the same patient who, after a episode of nigh-on in the left eye, developed in the right. You can see the splinter hemorrhages, the swollen optic disc, the absence of the cup-to-disc ratio. The next picture, Jay. And this is the same picture in the same patient in sequence over time. I'm sorry, this is a different patient in sequence over time. He presented with the slide on the left and the slide on the right at initial presentation. splinter hemorrhages on the right, on the middle photograph, which is his left eye, swelling around the optic disc, and a very normal looking optic disc on the left, but it's still a small disc ratio, small cup to disc ratio. The slide on the right shows the a left eye in evolution with smaller amount of hemorrhages. The next slide, Jay. And over time, you can see the pallor developed on the left eye, and eventually the right eye also developed superior disc pallor as well. And if you compare to the right and the left, they both look about the same at this point later on. That process took several months to develop fully. All right, next slide, Jay. So what's happened with Ozempic? How did this come about? What do we know from the news? Well, the news broke the story. And this happened in the first part of July. Next slide. It was all over the news and the media, and also in the trade journals and things like that. Next slide. My own ophthalmology group, the American Academy, and also the North American Neuro-Ophthalmology Society gave an advice statement and some information on this. And the blue screen on the right there, you see, that's actually from a Harvard medical school that I found out. So the next slide. So here is the title of the original article. Keep this on the screen for a little bit, those of you who want to read this study, but let me just talk about it in general for a few moments. And I want to point out that the contact researcher for this is Dr. Rizzo. He is a professor of ophthalmology at Harvard Medical School. He is a highly respected member of the neuro-ophthalmic community, and he is absolutely brilliant. When the data was presented to him, and here's how the whole story started. In his practice, there's a common room where all the doctors meet and see patients during the day. And at lunchtime, a resident came up and told Dr. Rizzo, by the way, I just saw a patient in the emergency room with Dion. It was a diabetic who was taking Ozempic. Another doctor in the room said, gee, I saw a patient, a different patient earlier this week, and Dr. Rizzo had one himself. So within a matter of 2 days, there are 3 people that presented with this problem in the Harvard Medical School at the neuro-ophthalmology office. And so they looked into this and said, gee, I wonder if there's something to it. It just so happens that the lead author in this article, which is Dr. Hathaway, is a master's of public health student. So immediately, Dr. Rizzo went to the Harvard Public Health School and had discussions with several of the academics on how best to determine any causative relationship of this topic. And after some thought, they reviewed their cases. And what they came up with was a retrospective matched cohort study. Essentially, they took all their neuro-ophthalmic patients from 2017, when the drug was approved, to November last year, 2023, and came up with a risk ratio, a hazard ratio of the addition of semaglutides to patients who are either diabetic or were taking the medication for weight loss. And what they found was, if you have type 2 diabetes, there's a 4.6 greater times chance of having non-ischemic anterior optic neuropathy if you're taking semaglutide. And if you're using it for weight control alone, the increase is 7.5 times. So The association is there because we do not know the underlying cause of NION. It's hard to say whether there's any cause and effect ratio, only there's an association. And I want to make this clearer to you. I'm an ophthalmologist. We know that many patients have glaucoma, especially in the Black population. Black people are associated with a higher risk of glaucoma. Does this mean that their skin color causes glaucoma? No, it's just an association. And this is a similar thing. Dr. Rizzo went on to say in conversations that each of these patients with this increased with NION who were taking semaglutides all had a small cup-to-disc ratio. They had the disc at risk. So what are we going to do in the future about this? How is this going to play out? Well, certainly more study is recognized. And certainly we don't know at this point whether the drug itself caused this problem or the change in metabolism in the body created this issue. It is probably a microvascular change that occurred with the use of the medication. To some degree, my own personal spin on this is that the name of non-arteritic ischemic optic neuropathy is probably a misnomer. And this has been in the literature since the 1950s. It was recognized decades ago. If small vessels around the optic disc are involved with this, these are the short posterior ciliary arteries, then this still is an arteritic form, but it's not a major arteritic form. So maybe a better name for this disease would be lesser or lower or lesser arteritic anterior ischemic optic neuropathy rather than non-arteritic. And maybe perhaps the giant stellar form would be a major arteritic form, or maybe we can number it different ways. Call one type 1 or one type 2, et cetera, et cetera. Nevertheless, there's no biopsy required for these patients, and it is what it is. Personally, as a practitioner, what I recommend is that patients who are going to be undergoing semaglutide treatment, either for their diabetes management or their weight loss, I think it's reasonable, even though the risk of this causing problems is low, I think it's reasonable to send them to the ophthalmologist and say, hey, your optic nerves are normal or your optic nerves are abnormal. Therefore, you may have a higher chance of this problem. It's a rare issue. It's a rare issue. Even if your local rate is 2 per 100,000 people and you increase it by 4 times, that's only 8 people per 100,000 per year that we're going to be showing up with this disease entity. It's a very low risk. It's a very low rate. But nevertheless, I think that patients may really wish to know about this entity to a greater degree. I think I have one more slide, Jay. And this basically is the numbers behind the talk. Again, just so you want to know, of the diabetic patients, 194 at semaglutides and 17 developed NION. 6 also diabetic patients had NION, but they were treated other ways. And the relative risk ratio of the type 2 diabetes was a 4.28 times greater. Of the overweight patients, there were 979, 361 is semaglutide, 20 of those developed NION, and 3 of the other overweight patients developed NION. And that shows up to be a much higher risk ratio. So therefore, it may be that the weight loss people have a greater risk. A last slide, I think, Jay. So again, this is an association, not a cause. It's unclear that the medication alone created this. There's no identifiable cause of NION. NION was more common in the type 2 diabetic group. I wouldn't be surprised because diabetes is already a risk. Since the disc at risk is the major known factor we have for identifying who may or may not develop this problem, it's not unreasonable for an optic nerve exam or a photograph of patients about to take semaglutides. I don't think that's unreasonable. We certainly need more studies. This is a difficult nut to crack because, unfortunately, the same ICD code for arteritic and non-arteritic ischemic neuropathy exists. They're the identical numbers. This requires a monitoring of your patients and separating by name in your chart rather than using the same ICD code. This will make further evaluation of this more difficult, and it may be that we have to have a separate ICD code for NION in the future. This may help identify risk. So it's not so simple as going through a nationwide study of Medicare data and determining where are all these patients. And Barry asked a question, and the answer was simply when Dr. Rizzo discussed this data, he said, yes, indeed. The people with NION in this study were the ones.
Grand rounds in the air. This is the Medical Image Radio Council grand rounds in the air for ID KN2M at the microphone for an interactive discussion about to have a discussion here and have question and answers. We're going to let WB1FFI and KN2M start the discussion off. Then we'll open up questions for the general community. Go ahead and Dave, if you would unmute. Go ahead, Dave.
Right, I'm unmuted now.
Go ahead.
Barry, your question?
Yes, can you hear me?
I have just fine. Yes, go ahead.
Yeah, no, I was just curious because I didn't notice it in the literature specifically if the identified patients through the epidemiology study showed that most, if not all of them, had the disc at risk, and whether this would be a valid screening protocol, or whether there were just some patients that had other types of discs and were ultimately diagnosed with non-arteritic ischemic optic neuropathy. Go.
Right. In Dr. Rizzo's oral discussion on this, he did mention that the patients with NION also had the traditional disc at risk. And as far as I can say, that was by a verbal report. I don't believe it was further identified in his study. I just looked again to see whether that was part of his study, Barry. So when it comes to identifying these people, my personal feeling would be if you have a patient with semaglutide and they develop this problem, now that we know about it, then at that point, we should possibly proceed to eliminate or stop the semaglutide in their patient protocol because the blindness or the visual loss may be a more important problem from that point on. Therefore, I think that the interruption would be relatively important. I think that ophthalmologists especially, or neurologists, need to be more aware of this issue. Does that help answer your question, Barry?
Sort of, because right now we obviously do not have a protocol for patients being who are anticipated to be put onto semiglutides being screened by ophthalmologists and or neurologists. So, and also looking specifically for discs, supposedly discs at risk, and providing alerts to the primary care doctors or endocrinologists who are considering treatment. Is that clear enough?
Right. And I think that I'm not sure if I would say screening is a the proper description to use. However, there are a certain amount of primary care docs who use photography to monitor their diabetic patients. And certainly that information needs to be brought out to screening centers to comment to the doctor requesting the study, uh, uh, whether we're just only looking for diabetic retinopathy, and now we have something else to look for. Now we should make a comment about the optic nerve. So therefore, I think this also puts into question some of the reasoning behind doing these photographic screening studies for diabetic patients in private practice, rather than sending to a qualified eye person, an ophthalmologist, or perhaps even an optometrist. Maybe we need to further educate those screening centers so that they're also looking at the optic nerve, making comments, so that practitioner knows if they'll go on to treatment with a semaglutide, there may be additional risk involved.
Makes sense. I understand.
I have a question, if I may.
We have a question from Munir. Is it N3PQ? Is that the call, Munir? N3PQ. We have a question for Dave KN2M. Let's pause one on the AHF side just for a moment before we proceed with questions and ID.
Yes, Dave, thank you for
This is the Medical Amateur Radio Council. Brandon's in the air, just pausing for one for ID. We have a question coming from Munir N3PQ for Dave KN2M. Go ahead.
Dave, thank you. And I have a couple of questions. First of all, I might have missed this. How soon after starting the semaglutide do you expect to have the NION? Question number two, is anybody looking at possible common mechanisms between the semaglutide NION and the PDE5 inhibitors NION, like, tadalafil and Cialis and Viagra and all the rest of them?
Roger, I have your question, Munir. I am not aware of any information that was released from Dr. Rizzo's study as far as the length of time after onset of treatment. Were there any trends to development of the NION? The study would be quite small. Obviously, we're only talking about a handful of people. So I do not have that information. That would be certainly a topic of high interest. As far as the mechanism go, yes, we have known about the issue with vision loss and optic neuropathy with Cialis medications for some time. That's been ongoing, and I have not had a patient recently in my practice with that. I have seen it though, however, and it was identified at the time, mostly due to the temporal association. You take the medication, your vision is lost an hour later, and the patient knows enough to report this to the urologist or report it to neurology. However, your question about the duration after onset of NION after receiving semaglutide is a really good one. And I'm afraid that we're not going to have enough information on that until a larger or more definitive patient group comes up. I'm not sure whether Dr. Rizzo can do that. It's probably going to be more of a national study, at least a question. And I will be going to the neuro-ophthalmic day at the Academy this year, and it certainly will be talking about it probably to some large extent. And that will be certainly one of the questions I will look for being brought up. If not, I'll raise it myself.
Question from KE5BQK, Linda in El Paso.
Yes, Linda, go ahead.
Yeah, I'm on Bydureon, which is exenatide, another GLP-1 agonist. Has anybody done any studies or seen anybody on that drug that has this?
The issue is your question is about other medications, and I am aware of the class of medications, but not any specific other issues. I think as far as a person to evaluate your own risk, it's purely a matter of looking at your portal, your chart, and see what is your cup-to-dis ratio. And if your doctor says it's 0.3 or 0.4, then the risk of this developing in yourself is much less, Linda. However, it would likely never be zero, but it would be diminished. Does that sound reasonable to you?
Yes, I think I'll talk to my doctor the next time I see him and ask him if he's familiar with this. And if he's, I've been on Bydureon now for 2 years, but I don't have any vision problems whatsoever. But I was just curious to see if that drug has been investigated or anyone seen with it, with that drug.
As far as I know, the issue from Dr. Rizzo's study did not mention that medication per se, and did not do subgroup analysis to any of the medications involved commercially. It was just a general class of medication involved.
Thank you.
I have a question.
Yes.
Hi, it's Mark WA1EXA out in Cape Cod. Is there any relationship between all the other side effects? Where did they see any of the patients also having the other side effects that could be used as a marker of higher risk when they did this study?
Mark, I'm not sure I heard your question. Would you please repeat it for me?
Yeah, was there any relationship between the other side effects of the drug that's already been identified and this problem, the ocular problem? Can you use some of the other side effects as a marker for people that may have this problem?
Yes, I understand your question precisely. And that also information was not brought up in Dr. Rizzo's study, to my knowledge. Again, we're talking about literally a handful of people with this problem out of 16,000 charts. And although the association is there, I think further studies will need to be done to determine any possible cause or causative relationship or diagnostic interpretation or with other side effects of these meds. So the answer to your question, Mark, is not at this time, and not that I know of course.
Thanks.
This is AA4FL, going to pause here for just a second, Dave. We're identifying here for the Medical Image Radio Council Grand Rounds on the Internet. This is AA4FL, KN2. Has been on the mic here. We're taking questions as well. Do we have any questions that come through the HF side? Go ahead and make your call to AA4FL. Okay, I'm not picking up any discussion from the HF side right now. Most of our members that are HF capable are also monitoring to Zoom. So we're trying to give you some consistent audio here, but this is a net. It's a directed net AA4FL being net control here at the mic. We're trying to make sure to identify and not only do our 10-minute identifications, but also to have each person that's transmitting, we're all licensed amateur radio operators here. They've been giving their call signs and their locations. So thank you very much for all of you that are letting us have the frequencies we do every week for the Medical Image Radio Council, Grand Rounds and Internet. I'm going to turn back the microphone here to Dave KM2M to continue with any follow-up and final comments.
Yeah, thanks, Jay. So thanks to everyone for their excellent questions and participation this morning. This has been a very, very, very interesting talk to research. And I certainly have a lot of questions on it. And I have seen this in my own practice, patient referrals. And it is of great interest to me. And one of the hardest things I can tell you as an ophthalmologist is to have a patient present to me with a problem for which I can not do anything to really help them. And specifically, there was a patient we had with this, and he was unable to drive or do his work anymore, and there was really nothing we could do to assist him in maintenance of his vision at that point, in spite of all our best intentions and high dose IV steroids. And I came right out with him. The first time I saw him in consultation was that, I'm really sorry, but we're not going to be able to help you with this, I don't believe, but we're going to try. Anyway, that's the hardest thing for me, is to be able to discuss with the patient that the help involved is limited, and we may not be able to give them anything of meaningful benefit. Very hard for me as a practitioner, as a physician. And thank you so much.
Before you go, may I ask a question? N4TSC.
Dave KM2M, we have a question from N4TSC. If you can take the question.
Sure. What is it?
Okay, Dave, sorry to bother you, but I just wanted to know whether I understood your original presentation when you talked about autoritic ischemic optic neuropathy versus non-autoritic. Did I misunderstand your presentation to indicate that autoritic ischemic optic neuropathy cannot be diagnosed other than by clinical presentation?
Well, let me just say this to you. Clinically, the NION is more of a clinical rule out type of diagnosis to present. If you show up in the hospital today, your emergency room with a vision loss, you will receive most likely a comprehensive evaluation by a stroke team and by a neurologist that will include blood testing. It will include a platelet count, a C-reactive protein, a SED rate. IL-6 takes a little longer to come out. It's a more specific test, but it's something that cannot be done overnight or even within a few hours. It's about a week. It takes about 5 to 7 days to come back. So let me make it clear. Clinically, I personally believe that one can have a very high suspicion of a giant cell arteritis patient in the emergency room or in your office. They have trouble with jaw claudication. They have trouble with pain and headaches. They may have a transient vision loss, obscuration. However, there is a definitive test for that, which would be either a biopsy of the temporal artery. In the US and Europe, there's actually an ultrasound that's usually used to ultrasound that vasculature. While I believe that I have a high degree of clinical suspicion that is giant cell arteritis, I also back it up by saying, yes, we can test you. Here are the things we're going to look for. Let's use those markers to determine your course of treatment. With NION, we have no specific test. We have clinical information. We have a swollen disc. We have hemorrhages around the disc. We have a small cup to disc ratio, possibly noted in the other eye. And those are more clinical entities. Will we back it up by laboratory testing? Sure, we will. We'll do those other tests, but they likely will not be as helpful. They won't show as much. Are we going to treat you the same way? Well, probably. Probably we're going to give you steroids, and I think we're going to draw the line at biopsy. We're likely not going to take a person with NION, or we suspect NION, into the operating room for a biopsy. It probably would not be done, but it might. Is that helpful to your understanding?
Carrie's muted.
Yeah, we N4TSC, we're not getting your audio transmission now.
Okay, let me try again. Can you hear me now?
QSL.
Okay, my question was really about the role of a temporal artery biopsy, because I didn't understand that that was part of your differentiation. And obviously, once you start steroids, you've locked out the possibility of learning anything from a temporal artery biopsy. But even so, even if you had a negative temporal artery biopsy, I think you could go ahead and treat, just under the assumption that maybe it's not developed quite yet in the temporal artery, and therefore you would go ahead and treat it. But that's the reason why I posed the question as to whether there was a differentiation clinically. Clearly, we have a problem when you're dealing with NION. But thank you for clearing that up.
Right. Well, the biopsy, once we start steroids, I give it about a week, a window of about 7 to 10 days. Outside that window, a biopsy just will not be as helpful. And that's why we like to do it, in the house and while the patient's hospitalized whenever possible. I understand your comment fully. I have had people with that have presented with similar conditions of giant cell arteritis. However, they have eosinophilic. Their biopsy comes back with eosinophilic infiltration of the artery, and clearly that's a different process. It's more of a Churg-Strauss thing. Something else at a higher level is going on. And those people, due to the generalized involvement of the ophthalmic artery, have very poor visual prognosis. They go on occasionally to develop anterior segment ischemia. They're much more difficult. They come up with neovascular glaucoma. Much more difficult people to manage, in my practice. However, they're out there. We do see them from time to time, and that also expands the diagnosis. So, are they giant cell arteritis? Yes, they are. But the biopsy itself indicates there's something else going on other than giant cells in the lumen of the arteries, or a breakdown of the intimal layers that typically we look for.
Okay, this is AA4. I fell at the mic. Hopefully everybody here is copying me on Zoom as well as on HF. We're going to go ahead and stop the HF portion of the net here. And we're going to continue on for Zoom for people that want to have further discussion. I'm going to turn the frequency back over to the general amateur community on 20 meters. Thank you for being here with us today on 20 meters. And we're trying to identify, and it's a net. It's a little bit of a hybrid net today. It can get confusing at times, but we do appreciate your patience and understanding. The Medical Amateur Radio Council doesn't usually talk so technically about medical subjects during our 20 meter net. However, this is something all amateurs should be aware of because it's such a timely important topic for you and your families and your family members. That, you know, the potential side effects from some medications that are very popular and growing in popularity, and the chances of having a negative outcome from that, you should be aware of. So feel free to follow up with questions. You can certainly email Dave, KN2M, at his QRZ address. You can also email me, AA4FL, about anything related to Marco at my QRZ address. But we're going to go ahead and bring the net to a close and continue on as a Zoom session. So 7.3, returning to frequency to the general amateur use here. This is AA4FL. Go ahead, Dave, and we're off the air right now, so everything you say now will just be for the Zoom session. Go ahead.
Yeah, I'm still here.
Any questions for Dave? Any more questions for Dave?
I do have a question, if I may, Munir and 3PQ.
Yes, Bonnie, I'm listening. Go ahead.
Okay, the study by Dr. Rizzo, do you know if they did any long-term follow-up? I want to know what happened to those patients long-term, and how does their prognosis differ? I know you touched on this, but how does the prognosis differ from those with GCA?
In general, my clinical experience with Nion is that the vision loss can be individually from person to person. The vision loss can be different. You could have a patient that will present with a segmental vision loss in the same eye and have the rest of the optic nerve damaged months later. It's highly variable. With giant cell arteritis, once the patient is under treatment and proper treatment, the chances of further or continuing vision loss on the opposite eye, or even in the same eye if we catch it early enough, is really, really, really minimized. Nion is a red herring. It can really come back and affect you at any time because, again, we do not know the underlying cause of this, only that we suspect it's microvascularly involved with the optic nerve head.
Follow-up question, if you please. Patients on semaglutide with diabetes, they probably should not be on PDE5 inhibitors, right, at the same time?
It's hard to say. Those are the people who might need that phosphodiesterase chemicals more than anybody else because they may have undergone peripheral neuropathy, neuropathic changes than male patients. I don't want to speculate on that one because I think it's outside of my experience level, and also you know, I'm not really a urologist at this point, nor do I want to be.
Well, thank you very much.
You're welcome. You're welcome.
Munir, thank you for asking the very intense questions, and I'm glad we're able to do this in the Zoom format. Don't hold back. I'm sure as a neurologist, your interest in this is very intense. But thank you for being here. Any other further questions for Dave? KN2M, this is AA4, even though we're off the air right now, continuing using call signs here for identification. Just gets me in the mood. You know, it really is a very important topic. I'm glad we brought it up on the Grand Rounds. We might have blown away the listeners with the intensity of discussion, but I think they got the point. I mean, this is a serious subject that's well worth talking about. So, and again, apologize for some of the some of the difficulties we're having. I had some problems with Zoom at the beginning. I had a mic, a USB port that wasn't being powered properly, and I had to change USB ports. So the first minute or two of audio on my end might have gotten clipped. So just goes to show you, amateur radio can be relevant. Yeah, we can have technical difficulties on the computers on the internet. We're getting through by HF. Dave, thank you very much for preparing this. It was absolutely wonderful, fascinating. I know from a standpoint of my family, it's going to be discussed greatly amongst friends and direct family. And there's somebody that probably not taking the medications, but would fit that disc at risk category. I further appreciate it. Thank you, Dave. I'll turn it back to you.
Well, in my own family, I do not have a large disc, and my son has the same thing that I do. So, am I at risk for this? I guess so. But not much we can do about it now. We can't trade in our genes anymore, Jay. We had a chance when we were little, the first the moment of creation. After that, we don't have a chance anymore.
I just would like to comment that I think that this dilemma that we have in making the diagnosis and picking these things out will probably be resolved probably in the next 10 years or so as AI continues to evolve and we're able to see things that we're not able to learn as observers, human observers, but we can pick out things as we're beginning to be able to determine what's going on with glaucoma, and we're able to determine those people that are at risk for glaucoma prior to them developing any symptoms. And I think the same thing is going to happen. And I think the issue that we have here is in the terminology that we use. And as you pointed out, you had to differentiate between arteritic and non-arteritic. And I think maybe we need to use better terminology, and that will help a little bit in terms of making these diagnoses.
Well, there was some information, some studies, but they're preliminary, and they didn't really pan out, of using OCT angiography on the nerve head in some of these patients to look at the microvascular circulation. It wasn't really helpful. So I don't have OCTA in my practice. It's not available to me. That may change in the future, but up until I think in January, OCTA is not going to be reimbursable by Medicare. So the number of OCTA machines is limited. It's mostly a research tool, and it's mostly useful for people with macular degenerative changes. But they're looking for, you're looking for a cart to fit the horse sometimes. So that's what I have on that comment. But yeah, deep learning may be helpful, and it really it's hard to say. Again, this has been around since Hay first looked at it as an ophthalmologist in the 1950s, and he was a brilliant clinician. His knowledge advanced of ophthalmology and retinal circulation was greatly advanced by his work. So even after all this time, we still have lots of questions.
If I can make an observation, this class of drugs is very popular, and there's no reason to believe that the use of the product, particularly for weight loss, is going to be used probably with no or limited medical intervention at some point. It's already being used that way. There are clubs out there that are providing it. So the possibility of side effects and problems coming up are going to be significant just because of the number of people that are using it without medical control. So I think there is going to be it's going to continue to be a problem until we know more about this.
Well, fortunately, it's a rare issue.
Fortunately.
Yeah. I like your shirt. That's the black dog.
Oh yeah, Martha's Nantucket.
That's right.
Yeah.
Very familiar.
Yeah, I'm in Yarmouth.
Yeah.
Okay. Thank you. Thank you very much.
Mark, it's great to see you back here and active.
Yeah, I've had some surgery. I had a hip replacement. My wife's had a number of surgeries. It just hasn't worked out. That's all.
Yeah, life does get in the way. Life cycle solar cycle, and I guess our parts to start to be affected with longevity.
Yeah,
But
I
thank
guess
you.
we can get replacements.
Yes. Well, it's certainly a very timely subject. We appreciate bringing up Dave here. I've continued the recording on the Zoom session so we can make this available to all our members, Dave. It's that important of a topic.
Cool.
And of course, the depth that we're talking about the subject now will be of
Yeah.
great interest to our
I
members.
guess very rare that we get something so timely to show up in any specialty that's so controversial. And I think this is just a wonderful way to get the word out and talk to people. Again, I'll be having another lecture this week to the neurologist on this in Buffalo, and that's a statewide lecture. So we just get the word out and proceed with all these wonderful questions. I do appreciate the questions that came up today. I think they were excellent. And I thank you so much for allowing me to do this, Jay. A lot of fun.
The pleasure is all mine for having you the honor. Mark, did you have another comment?
No, I'm just saying bye.
Okay. 773, Mark.
They'll see ya.
I hope to see you on the digital. That's again too.
Oh, is it still on? I was on to ask you that. You still
Yeah,
doing it?
it's still on.
And what's the time on Saturday?
9 a.m. Eastern on Sunday,
9
right before the net here.
Sunday.
Right before the net here. Right before the net
Okay.
here. But we might do a Thursday night edition, but we need a few more to get at KD5 QHV, our immediate past president, got active on digital now, so we got him on with the dongle because that way
Is it still on QuadNet?
still on the QuadNet array, but you got to come in through D-Star. They're not supporting Brandmeister anymore. If that's going to affect you.
Oh, okay. All right.
Yeah, the technical difficulties we have. Dave, are you saying 7.3, Dave?
I have not, but that doesn't mean I can't learn.
7.3. 7.3.
Bye-bye.
Any other questions from me from a standpoint of Marco? And thank you for everything you've done here at CHIP as well, Munir. Safe travels, please. Safe travels. I do want to see some photos, so I hope you'll take the time to send them. I'm really looking forward to having students that have done this trip last summer that have families there and telling me how beautiful everything is. I'd love to see the photos.
Thank you.
Okay, I'm going to say 7.3 as well, and then the recording. Identifying out of non-necessity, but out of habit. This is AA4FL bringing the Zoom portion of our Grand Rounds on the Internet to a close for today. See everybody next week.